as I told you earlier, we would have Dr. Perry Fleisher here from ACMC on, cardiologist. How you doing?
Good. Good morning, Pat. How are you?
I'm doing great. Is it warming up at all?
No.
No, it's still too
No,
cold.
it's due to get colder from what I understand.
Actually, it's supposed to have some snowflakes, and there is a storm system coming across the lake, so by the time we leave here this morning, it could be raining outside.
Yeah. We had a few sprinkles this morning on my way in.
Did you really?
Mm-hmm.
You've been on the show before.
Yeah, this is my 4th time now.
Is it 4 times now?
Mm-hmm.
Your name, it was funny, my neighbor brought your name up the other day when I was talking to him. He said that you were a doctor, and I know Perry Fleisher. I have him on the show, so it was good to hear that he was very familiar with you. We're going to talk about anticoagulation. Is that what it is?
Yeah, last time I was here, we talked about atrial fibrillation, one of the common rhythm irregularities of the heart, and we touched on the need for anticoagulation as part of the treatment for that. And I thought, especially with some of the recent commercial notoriety in the media, that today would be a good time to probably dovetail into that and talk about anticoagulation.
Fine. This in basic terms is called blood thinning, is that what you call it?
Yeah, it's one of those pet peeves that we all have, that it's what the public knows anticoagulation as they call it, blood thinning. And that conjures up all sorts of images of thin, watery blood, and it's really an incorrect term, though. And what we need to know is that the medicines that we use to effectively limit the amount of clotting that the blood does doesn't really change the thickness of the blood. It's not like turning maple syrup into water. It's not, as we call it, viscosity. It's not actually making blood more easy to flow, or more easy to, or less easy to flow, which would be what we think of when we think of blood thinning. But rather, what we're doing is we're interfering with the clotting mechanism in the blood, and doing that in a calculated and therapeutic way.
Would this be similar to at one point years ago, I had a very high blood pressure problem, and they thought that I had something near the heart. I think it was, I want to say, a clot or something. It turned out it was a shadow.
Yeah.
But for 6 months before they figured out it was a shadow, I was on Coumadin.
Correct.
And they told me I couldn't eat greens and I couldn't eat grapefruit, I think.
Absolutely.
Is there a reason?
And we're gonna, and we'll talk about that. Coumadin was the brand name for the drug warfarin, which has been with us for a very, very long time and has been the main anticoagulant that we've used over the course of time. Actually, we've been using it for more than 45 years now.
Has it been that long?
It's been around for a very, very long time.
It still is being used.
And we still use it. It's still, to this day, I would say, probably has the largest share of use as far as the anticoagulants that are in prescription use.
Which I guess would take me to the next question, is why do we use anticoagulants? I mean, why is that?
Well, anticoagulants are an integral part of treatment, especially in heart and vascular disease, but in other conditions as well. We have a very, very marvelous protective system in our bodies, which is the clotting mechanism. And, it's not simply blood laying in a pan and becoming a solid. It's not like Jell-O congealing in the refrigerator. Our blood has a very, very complex system of chemicals in it, which are designed to allow it to go from a liquid to a solid state. Now, we developed this over the course of time. It was evolved over time, it was given to us as a gift to protect us, because our life is dependent on keeping the blood in our body, as you know, and various types of both disease as well as injury can threaten the body as far as losing blood is concerned. And so when an opening that's abnormal is created, whether it's a cut or whether it's some type of an infection that's damaged some of the blood vessels or the tissues, and the blood starts to leak out, this chemical system is activated. And you can think of the system as a set of falling dominoes. There's multiple steps chemically in the process that ends with the blood coming together and forming semi-solid material, which we call a clot.
Right.
And we've all seen this happen. We cut ourselves, it bleeds profusely, we hold it, we slow the flow of blood, and eventually we have the bleeding stop. Now, unfortunately, there are some diseases that we acquire that cause that system to be activated abnormally. And so while clots are a good thing to have when we have a leak someplace, they're not a very good thing to have when we want the blood to flow through a blood vessel, especially to some of our vital organs like the kidneys, the brain, the heart, and so on. And so consequently, when we have these abnormal conditions, whether it's cholesterol plaque buildup in the blood vessels or some other abnormality of the lining of the blood vessels, we want to, medically, we want to inhibit that clotting mechanism so that we don't form abnormal blood clots that can harm us. Mm-hmm. In the case of what we talked about at my last visit with you here, the rhythm abnormality we call atrial fibrillation, we had pools of stagnant blood in the upper chambers of the heart. And one of the things that activates allows the clotting system to activate is very sluggish flow. If we have a pool of blood that's not moving very quickly, again, going back to the example I told you earlier, if we cut ourselves, the first thing that we're told to do is put pressure on the wound. Well, when we put pressure on the wound, we slow the flow of blood into that area, and slow-flowing blood is more clottable. And so when we have areas where there's slow flow, we can get these abnormal blood clots. If they occur in a large chambered organ like the heart, these clots form on the inside lining and eventually grow large enough to break loose and travel in the bloodstream. And if they lodge in a critical blood vessel in the brain, they can cause a stroke, which is one of the most feared events. They can lodge in the heart's arteries and cause a heart attack, and they can go out to the other parts of the body and do all sorts of mischief out there as well. And so in those circumstances, we would like to slow, not interrupt, but slow the process of clotting so that we have less of a chance of forming these abnormal clots that can harm us.
So, like when you cut yourself shaving, and all of us have done that, it seems like it's forever to get that to stop.
Yeah.
You know, so that's a good clot. That is considered a good clot.
Absolutely.
It's the one inside of us that in the arteries, in the veins that we have to be careful of. Now, I guess maybe you could explain. I don't understand the clotting system, how it really works. I guess I don't understand how it breaks. How does does a artery break or something, and that makes the blood flow?
Well, if we're talking about the clotting system itself, as I mentioned, it is a series of chemical events that, again, and I was going to bring a set of dominoes with me today to show you, but we've all seen these demonstrations with people setting up these sometimes very elaborate displays of multiple dominoes on a table, and you just knock over the first one, and it cascades all the way down, and finally the last one falls. Okay, well, the last one that falls is the change in the blood from a liquid to a solid. That's when the clot forms. Okay? But there's multiple places in this scheme of falling dominoes that can be used to activate the system. You don't have to just knock over the first one and have it cascade all the way down, but rather I could come to the halfway point and knock one of those over, and while these wouldn't fall, eventually we would get down to the clot. And this was the purpose or intent of having this complicated system, because there are multiple different ways in which injury or disease can occur that we would want the body to clot, or the blood to clot. And so the activation point in this sequence may be different for every different type of injury or disease, right, but the end result is the same. And so we also know that if you watched one of those demonstrations, if there's one out of place, or if even worse, you were to reach in and take one domino out and then try to trigger the system, the cascade will fall to the empty spot and then it'll stop and you'll never get to the far end. Mm-hmm. And basically that's what we're doing to a limited extent with these medications.
I see.
We're trying
that makes sense now, the way you put that.
So, people ask, well, why is the clotting system so complicated? Why not just go from stimulus to clot? And the answer is because there's no guarantee that the stimulus is going to occur at the head of the cascade. It may occur somewhere else in the mechanism. Now, in order to accomplish this, we have to somehow interfere with this cascade. And we do that chemically with the medications that we have. Now, before I get into the actual medications, what we need to understand is that we're interfering with a process that does both good and bad. So if we have the disease that blocked arteries or sluggish or irregular heartbeat, we're at risk of forming these abnormal or bad blood clots. However, we also still, even if we have that disease, we're still subject to the risk of injuring ourselves. We can still get ulcers. We can still get other conditions in which we want clotting to occur. So the use of blood thinners has to be a very regulated and very carefully calculated treatment in order that we don't want to take away clotting entirely. We don't want to take one of those dominoes out completely so that the blood can't clot. We want to somehow make the system respond in a less rapid or less aggressive fashion so that we can still clot when we need to. Maybe it takes a little bit longer, but we can still get blood clots when we want to, but we've dropped below that threshold where the abnormal blood clots can form.
What do you have to do blood tests to make sure that the numbers are correct?
Well, if we talk about the last 45 or 50 years with warfarin, the answer is absolutely yes. The way in which these medications work is quite different from one drug to the next. And as a result, with warfarin, we're working in a way that the response is different from person to person. In fact, the response to warfarin can be different in a single individual person from week to week, depending on a lot of different factors. And we'll talk a little bit about that.
Okay.
But the point is that with warfarin, we're constantly monitoring the degree of anticoagulation in an individual and adjusting the dose to match what our goals are.
Mm-hmm. Mm-hmm. I think you kind of touched on it, but I wanted to ask you this before I forget it. So in other words, when you're on these anticoagulants, you have to monitor because there could be other problems that you're not just looking at the heart. In other words, say when my dad was on it, I think he was on it for a long time. They were always concerned if he cut himself that he could lose too much blood because of the clotting system not working.
Absolutely.
Right. So that's one of the problems.
Yeah, we know that when it comes to anticoagulation, therapeutically, when we have already diagnosed that there's a need to initiate anticoagulation in a patient, we are going to walk a tightrope at that point between having too much anticoagulation and interfering with potentially life-saving clotting mechanism, such as a severe injury. And it's not likely that from a minor cut a person is going to bleed to death even with these medications, but from much more severe injury, from internal bleeding that can't be seen, such as I mentioned, bleeding ulcers and that sort of thing, we can get a situation where the bleeding is profuse and doesn't stop because we've interfered too much. And on the other hand, we can have a false sense of security. It's just as equally bad to not give enough of the medication and not prevent the clot that's going to cause a stroke.
Mm-hmm.
And so we have this very, very narrow, as we call it, therapeutic range for treatment with these medications, where too little may be very bad, and too much certainly may be very bad as well.
Okay. So we've touched on the conditions that we have in that. So then, can we go into the medications now?
Absolutely.
Okay.
Absolutely. We talked about warfarin already.
Right, and we talked about possible dangers. Are there any other dangers for treatment?
Now, really, what everybody needs to understand as we talk about the newer medications is that so far there's no utopia. There's no perfect solution for this. Anytime that we interfere with the clotting mechanism in the body, we're going to get a situation where bleeding, be it normal or abnormal, well, bleeding outside the body is never normal, but bleeding is going to be enhanced. We're going to have more bleeding if something happens, if we're injured or have one of those other diseases. There's no way of getting around that. If you anticoagulate a patient, that patient is going to have a higher risk of bleeding. It doesn't matter which medicine we use. Mm-hmm. So whether it's warfarin or one of the newer medications which we're going to talk about, there is a risk of bleeding. And perhaps the most common reason not to use these medications is in those people who already have demonstrated some form of major bleeding problem. As I mentioned, if you come to me and you may need anticoagulation for one reason, but you've just recently had major surgery, or so in that patient, perhaps temporarily they shouldn't be on blood thinners. But if you have a problem with recurrent bleeding ulcers or other types of internal bleeding, those are people that we would like to put on anticoagulation to prevent clots, but sometimes we just can't because the risk is way too high. So what we need to understand is that there is no way yet that we know of to prevent abnormal or bad blood clots and not risk increasing the risk of bleeding at the same time.
What are the dangers? Is there any danger of not treating?
Yeah, obviously the reason that we want to treat is to prevent these abnormal blood clots. And for instance, as I mentioned last time we visited together, the atrial fibrillation in the general, especially in the older population, has a risk of stroke that is about 4 to 5 times higher than the general public, not in atrial fibrillation. So about, in that particular case, 5% per year risk of stroke, and stroke is, as we know, is an extremely morbid event that's obviously good to avoid if we have the means at our disposal to do it. And so, again, it's a balancing act. We want to prevent the stroke. We're going to risk some bleeding, and it's a very, very calculated risk that both the physician as well as the patient need to understand as they go into the treatment.
Reasons not to treat.
Well, as I mentioned, the major reason not to treat is risk of bleeding. Somebody who has demonstrated disease process that's not correctable, that predisposes them to bleeding, somebody who has a bleeding disorder. We know that there are some hereditary bleeding disorders such as hemophilia and so on. These people obviously are not candidates for, are usually not candidates for anticoagulation. For patients who have a high risk of injury, that's another situation where we really have to think twice. They may not have an increased risk of bleeding because of disease, but they're in either a profession that predisposes them to physical injury, certain types of high-risk construction, and so on. Not all construction. These are people in whom we really need to discuss that they're not absolute reasons not to treat, but they're concerns. And obviously, you wouldn't want to start, let's say, a professional boxer or on blood thinners. There, I use the term for you, on anticoagulants.
But you know what? Boxers probably would not be able to box if they have a heart condition.
Well, but they might have some other condition that they need to be on anticoagulation for, other than a heart condition. But you're right. A lot of the people that fall into this category fall out of the categories of high risk. One of the highest risks is we see in very, very elderly and debilitated patients, especially those who have they may be in an extended care facility, nursing home, or they may be have some type of brain disorder such as Alzheimer's disease, which unfortunately can strike younger people as well. I don't want to confine this to the elderly. These people are at much higher risk of tripping and falling, bumping into things, and especially having head injuries. And those are people that we really need to think very, very carefully about the risk to benefit ratio, the merits of either treating or not treating.
I have 2 scenarios for you, okay? A person that needs an operation, obviously bleed in the head, would you have to be counseled on that before that operation is held if they are get back on a blood thinner.
Absolutely, and most of the patients who are on blood thinners, there it is again, on anticoagulation, most of those patients that are coming up on a need for surgery, a foreseeable need for surgery, not this emergency thing, but
right.
Most of them are going to have their anticoagulation therapy stopped in advance of the surgery.
How long before?
And it varies from medication to medication. Okay. And probably that's a good point to talk about some of the newer treatments that we have.
Okay.
As I mentioned, warfarin's been around for close to 50 years at this point. And we've known its limitations for many years, but unfortunately it was all we had in terms of oral anticoagulation. We know, as I mentioned, that we can't predict the dosage from individual to individual with this medication. We can't predict the consistency of the dosage in any one individual. It requires frequent blood tests, and it has a lot of interactions with other medication and with foods, such that it's a particularly difficult medication to use. And the incidence of people on warfarin coming to the laboratory, having a blood test, and finding that they're out of the desired range for blood thinning. They're either not anticoagulated enough, or they are more anticoagulated than they need to be, is very, very high. And so that's a problem that we've wanted to be able to solve for a long time. Now, warfarin interferes with this domino scheme in about 4 different places, and works by decreasing the amount of 4 of the dominoes, if you will, 4 of the chemicals that are produced in the body. And as many of our viewers probably know, if they've been on the medication, it works by interfering with vitamin K. So certain types of vitamin supplements with vitamin K in it are used, can be interfering with that process, and foods with a lot of vitamin K in it. Recently, and by that I mean over the past little more than a year, about a year and a half, the FDA has approved 2 new medications, the first 2 new ones in close to 50 years, that can affect anticoagulation in certain cases, certain diagnoses. And specifically here we're talking about atrial fibrillation. So before I go any further, the new medications are only approved for use for atrial fibrillation right now. So as far as stroke prevention, atrial fibrillation, that's a go. But for patients that are on anticoagulation because they have artificial heart valves or blood clots in their lungs or their legs and so on, these medications are not appropriate to use at the current time. These medications have a greater advantage over warfarin in that they are much more predictable. They block only one of the dominoes, if you will, and they do so very, very, well, accurately is probably the best word for it, very consistently from person to person. And so within a certain narrow range, there's only 1 dose of the medication for each individual, and there is not a need for constant adjustment or blood testing with these medicines. The downside to these new medications has been a concern that, unlike warfarin, which we can reverse, which we can give an antidote for, which is either certain types of blood transfusions or giving large amounts of vitamin K intravenously, these new medications can't be reversed. You have to, if you have a sudden need to have the blood anticoagulation come back to normal very rapidly, you have nothing but time on your side. Fortunately, for most people, if their kidney function is normal, that time is about 48 hours. So the advantages of the new medications are they're more accurate, they're easier to take, they have less interactions with other medications and food, and most importantly, they have, at least initial studies have shown that they have a perhaps more accurate or more effective stroke prevention characteristic than warfarin does. Our biggest concern with these patients that have shown up with a stroke with atrial fibrillation. When we've examined them in the emergency room as they come in, we almost universally find that the one factor that's consistent throughout all of them is that their degree of anticoagulation was not up to the levels that we wanted. And so that's something we can put behind us with the newer medications. There is no, as I mentioned before, there is no utopia though. These medications have as much bleeding risk as the warfarin does. So we're not talking about necessarily safer medicines in terms of bleeding complications, but we are talking about medications which are perhaps more effective in preventing the stroke from occurring.
Earlier in the interview, I kind of alluded to grapefruit and lettuce, I think it was, or spinach.
Leafy green vegetables.
Yes. Is that vitamin K?
That's vitamin K.
So that would.
Well, excuse me. I take the for the leafy green vegetables, absolutely. That's vitamin K, and that is the antidote for.
So if you ate that, it would not warfarin would not be effective?
That's correct.
Okay.
If you eat enough of those, if you suddenly change your diet and start eating a large amount of salads and Brussels sprouts and other leafy green vegetables, you're going to prevent the warfarin from working as an anticoagulant. Now, grapefruit, on the other hand, has a number of substances in it, at least one of which is an inhibitor of a specific chemical step in the liver, which is used for the liver to metabolize, to break down the warfarin. So in the case of grapefruit, you will actually raise the amount of warfarin in your system because the liver is not disposing of it quickly, and your blood will become more anticoagulated.
Nice. Opposite. We're getting a phone call. Give us a call back. We'll take your phone calls now, 593-7181. While we're waiting for that phone call to come back in, here it goes. We'll take it right now. Hi, you're on the air.
Good morning, Pat. This is Earl.
Hi, Earl.
Had a question for the doctor.
Sure.
I had a heart attack in '06, and I was on Plavix. I had 2 stents put in the widowmaker arteries, and I've been on Plavix up until now, and then they finally took them off. Does that mean anything as far as, being on it and then taking you off of it? Like for the stents, what does that do for them?
Well, Earl, I'm glad you asked the question because it was the next item I was going to actually talk about. Because people ask when we talk about anticoagulants about aspirin and some of the other similar acting medications. You mentioned one trade name, which was Plavix. There are several others in the same family of medications that Plavix is in. These are what we call antiplatelet agents, and at the risk of confusing everybody and complicating the issue, there's one element in blood clotting that I've really not talked about today, and that is that we have these blood cells circulating in our bloodstream called platelets, and they are actively involved with the clotting process. They're one of the ways that this chemical system I talked about can knock over the starting domino. And if you inhibit them, you are preventing one of the steps in the blood clotting process. However, when we inhibit the platelets, we're really, clinically, we're preventing blood clots in small blood vessels, whether it be the heart arteries here or that we're talking about, or the smaller arteries in the brain, or the arteries in the neck that lead to the brain. These type of blood clots tend to be very small or microscopic blood clots, and they can be reduced by inhibiting these clotting cells called platelets. Aspirin does that, Plavix which is clopidogrel, does that. But these drugs do not prevent the large blood clots that occur inside the heart that can lead to, that we see in atrial fibrillation, for instance. And so they really don't have a role in the large blood clots that we see in heart, veins, and artificial heart valves, and so on. So they are important. They are blood thinners, and specifically in this particular question, the when a stent, which is usually made of stainless steel, is placed in the arteries until the artery lining heals over the stent. Bare metal is one of the means that these platelet cells are activated, and so when we put a stent in the arteries, we always put people on aspirin and one of the other antiplatelet drugs for a period of time, and once we're convinced that the stent is healed and the bare metal is no longer exposed to the bloodstream, then at least one of the antiplatelet drugs can be stopped. And that's what I suspect has occurred here, is that a sufficient period of time has passed that the doctors have felt it's safe to go on with perhaps just aspirin alone, which is quite common.
That's what he put me just on aspirin a day, a little bit stronger than the one that I was taking right along, because I had a blood clot there too. So he said I was very lucky that I made it, because so
we're glad you did, Earl.
Yeah, and but anyhow, I just kind of wondered. I've been really doing well. I just had a stress test, and it was supposed to have that one they shoot the stuff in you, but I hated that. So I stayed on that treadmill as long as I could. I got my heart rate up, and thank God that I didn't have to have that stuff put in me. But
well, good, because that's still the best way to do it.
Oh yeah. Well, thank you very much. You guys have a good day.
Thanks, Earl.
Bye.
Bye-bye. Question came in while we were doing that talk there. What about hemorrhoids, bleeding and hemorrhoids? Would that be a problem?
It can be in some people. Hemorrhoids usually cause only minimal blood loss. Any of the anticoagulants will probably increase that to some extent, but it's a rare individual that is going to have life-threatening bleeding from the hemorrhoids. But having said that, there are those rare individuals that will. So, but those are usually people that can be identified ahead of time.
Yeah, it's like you say, you're watching each individual patient.
Absolutely.
I guess we can close this out, Doc, with what is the future of these treatments? Have you seen changes coming up?
Well, someday I suspect that we'll be able to target the initiating factors that cause abnormal blood clots to occur, as opposed to the normal and protective blood clotting mechanism, and be able to prevent only the clots that cause harm and not the ones that do good.
Yeah.
I don't know if that'll be during my career or even during my lifetime, but I suspect that's the direction that we want to go in, eliminating some of the factors that cause the clots to occur, or interfering with those processes, where the future is going to be. In the near-term future, we're going to see a new series of medications occur that are in the same family as the new ones that have been approved so far. I think we're at 2 right now. The third one is probably going to come online in the next few months. And each one is going to have perhaps a little different flavor, if you will, for what type of blood clots and what type of individual patient they're going to be best suited for. And it's going to be a more complicated but perhaps more effective and more safe environment for patients.
Good morning, you're on the air.
Yes, I have a question. I had an artificial heart valve 12 years ago, and I've been on warfarin. And my question is there, and I also have arthritis, and is there a reference source available that I could check what joint pain remedies would interfere with the warfarin?
Well, I would start off with the product reference information. Your pharmacist certainly would be a good source for starting with that. The warfarin has a very large number of drug interactions with other medications, and there are also certain, especially when it comes to arthritis, there are also certain medications that may not interfere directly with warfarin, but can lead to an increased risk of bleeding, especially internal bleeding, that you want to avoid. So In terms of a reference, there is certainly the product information that is available both online and at the pharmacy. There's also, most of the pharmacies have very good and comprehensive handouts that go with the prescriptions, and I would cross-reference both the one that comes with your warfarin and the one that would come with one of the potential medications that you want to use.
One other question, like if I went to a nutritional source that's not a prescription, like homeopathic remedies, is there any kind of a book or that would reference those?
There are several books out on the market, and I at the current time the titles escape me, so I can't tell you off the top of my head which books there are. But there's several good books out there about herbal and alternative medications that you can do. That's a subject for another whole talk here. But there are references out there, of course, also on the internet. I would caution you that the big problem with the homeopathic treatments is that there is today absolutely no body of regulation for the content of those commercial substances that you can buy at the both at the pharmacy as well as at the nutrition stores. So the bottom line is you don't know what you're getting. The labeling on those is not regulated by law, nor is it overseen by the FDA. And so I would caution you that unlike a medication, if your warfarin says 4 milligrams, you can bet that plus or minus less than 1%, you've got 4 milligrams of warfarin in each of those tablets. A homeopathic substance that you buy that says 100 milligrams on the label could have anywhere from 0 to 1,000 in it, and nobody's looking over their shoulder. So I would be extremely cautious about pursuing any homeopathic substances or supplements without discussing them with your physician.
Okay, well, thank you very much.
Thank you.
Mm-hmm.
Very good. Doc, you're, how many days a week are you in Ashtabula?
My partner, Dr. Stevens, and I are in Ashtabula 5 days a week plus on-call.
Okay. If somebody wants to get a hold of you, this number is the correct one, 994-7622?
That is absolutely correct.
Okay. Because I'll always get questions, how do you get a hold of that doctor you had on the other day? So I'll keep this around. Very interesting topic, and Elaine told us here before we went on the air that you will be coming back more often than in the past.
Yeah, we're planning on doing at least a quarterly program for you, and I'll try to vary the content as much as possible, and if I can bring some items to show people next time around, we will.
Please do. Please do. Great talking to you, Doc.
My pleasure.
Thank you.
I've been asked to say hi to my office staff.
Okay.
Over there, Nicoletta, Heather, and Kelly are avidly watching on the computer in the office, and they're just absolutely great people, and they make my they give me the ability to do what we do in the office. So
they're the ones that help us get by.
Good morning to you also.
That's great. Thank you so much, Doc.
Thank you.
Dr. Perry Fleisher, if you have any concerns that you think you need checked out, Dr. Fleisher is available at the Ashtabula County Medical Center, and the number is 994-7622.